Hello, good evening. Welcome back to my IVF and the European Fertility Society. We are back once again with Dr. Harry Karpouzis. You can see him right here. Hello, Dr. Harry. Welcome back. How are you?
I'm fine, Caroline. Nice to see you again, and nice to see everybody. I'm very keen on speaking about this very interesting subject.
Definitely. It's a great topic to discuss, not an easy one. So I'm glad we are going to talk about it today. So we will talk about immunotherapy in IVF and recurrent pregnancy loss. So not an easy topic, as I've mentioned, but we have the expert with us. So Dr. Harry Karpouzis will start with his presentation on this. But afterwards, I know you will have plenty of questions. So remember that we will have around 30 minutes for the questions. So you can type those in the chat and Dr. Harry will definitely answer them for you. So don't hesitate, all is anonymous. And remember, it's also recorded and will be available on our website. And I believe that we do not need to wait any longer. Let's go for it. It's a great topic. So let's get going with our presentation first, okay?
Yeah.
Perfect.
Okay.
Thank you so much indeed.
You're welcome. So we will talk about immunotherapy in IVF and recurrent pregnancy loss. It's a difficult topic. Many of the slides have lots of medical information on it. So some of the slides that are a bit more complicated, I will pass them quickly and I will try to stay to the important things that you need to know about immunology and reproduction. First of all, we will talk about the role of immunology and reproduction. It's a complex dance. This is how we usually characterize it. The role of immunology is dual. First, immunology safeguards the fetus from developing threats, but also it allows for the development and implantation of an embryo. So we have a very important balance in the endometrium, in the implantation window. And conception itself is a process that really challenges the immune system. Why? For example, we know that the sperm carries paternal genetic material. This is material that it is foreign entity to the female body. Even when we are talking about donations, the donor egg is also foreign to the endometrium. The immune system has the ability to recognize and tolerate the sperm, and this is very important for the natural conception. And then conception happens, and then the immune system must exhibit tolerance towards the developing embryo. Because if it keeps attacking the embryo, it can cause problems like miscarriages, for example. So we have a balance between the regulatory immune cells that suppress actually the immune responses. And also we have the natural killer cells, the very famous natural killer cells, which are kind of a bit different in the blood and the uterus. And their presence is very important for proper implantation because we hear natural killer cells and we say this is something bad. It's not bad. They are very important for the proper implantation. What is causing problems sometimes, it is the overactivity of them. Many different cells that play a role in the immune system. The uterine natural killer cells, actually, what they do is that they facilitate the tissue remodeling. They help with the trophoblast invasion, which is the placenta invasion, okay? And also the placental growth. On the other hand, the natural killer cells, if they are overactive, they can also inflame and destroy tissues. So it's again what we were telling before about many different cells, many different cytosines that play a very important role in the implantation window. What we will be talking today, we will be talking about recurrent miscarriages, recurrent implantation failures, autoimmune disorders and fertility, the natural killer cells and the autoimmunity, the antiphospholipid syndrome that most of you most probably have heard about, especially between people that have a history of recurrent miscarriages. We will say a few words about the HLA and KIR, and also some things about the endometriosis, because the endometriosis as well, it is associated with very often with many immunological issues. Let's go to some statistics. 15% of the patients that enroll into IVF have a history of recurrent implantation failures, and 1 to 5% of the patients have a history of recurrent miscarriages. Let's go to the definitions. We have explained these in the previous talk that we had as well. What is recurrent implantation failure? It is the failure to achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycles in a woman under the age of 40 years. This is the definition of recurrent implantation failures. And what is the definition of recurrent miscarriages? In the past, it was 3 or more in a row miscarriages. The definition has changed. Even 2 or more miscarriages is considered nowadays to be recurrent miscarriages, and it would be good, especially in the private sector, to be investigated. Let's talk about some autoimmune conditions, many autoimmune conditions. Lupus, a very often one, Hashimoto, thyroiditis, the antiphospholipid syndrome, rheumatoid arthritis, MS, type 1 diabetes, less common like scleroderma and Sjögren, vitiligo. All these autoimmune conditions, many times they are associated to each other, or they can be independent. But many times we see that Hashimoto and vitiligo, for example, and Sjögren are together. And all these conditions create an immunological status that can affect pregnancy as well. Let's go to antiphospholipid syndrome. It's an autoimmune condition. It causes hypercoagulation. We identify it when we have antiphospholipid antibodies, and it causes either thrombosis or pregnancy loss. And the pregnancy loss can be even in the late miscarriage. This is quite common in antiphospholipid syndrome in the 2nd or 3rd trimester, and also puts people into a higher risk of stillbirths. Sometimes it is associated with primary infertility as well, and sometimes it is associated with pregnancy complications like IUGR, small babies, and preeclampsia. How does it cause problems? It causes problems by placental thrombosis. It causes problems by the complement activation, which actually triggers a cascade of thrombosis inside the decidua and inside the placenta. It can cause inflammation, can be combined, of course, with other autoimmune conditions. It's not often, it's 1 in 2,000 usually. It's more often in women that have pregnancy complications. What is the treatment? It's anticoagulant treatment like Clexane, injections, aspirin, and many times, especially in refractory antiphospholipid syndrome, and proper antiphospholipid syndrome, hydroxychloroquine, the Placanil, also helps. And all these are the antibodies that we usually have. We might have 1 of them, 2 of them, or all 3 of them. And obviously, when we have all 3 of them, the antiphospholipid syndrome is more risky and more dangerous for a pregnancy. Very important about the criteria, because many times we say, okay, you have antiphospholipid syndrome because you have raised antiphospholipid antibodies, but it's not that. The criteria need to have at least 1 clinical event, either a thrombotic event or a pregnancy complication, and detection of 1 or more antiphospholipid antibodies, the lupus, anticoagulant, the anticardiolipid, and the glycoproteins. So the criteria are very important because we cannot put a label to people that they have antiphospholipid syndrome without really having antiphospholipid syndrome. Now, what I wanted to talk about today and what we usually apply in our practice at Pelargos IVF. There are many people that do not believe in immunology. We don't believe either in checking about immunology in people that do not have a history of recurrent miscarriages, recurrent implantation failures, unexplained implantation failures. But in candidates that do have all these issues, immunology and personalized approach can make a difference. We really believe that. We had very good results in our practice, and we strongly believe that the benefit is behind personalized approach of each case, because we see many times people that say, okay, it didn't work, let's give steroids. It didn't work, let's give intralipid. Why? We don't know what is the issue. Anyway, the uterine immune reaction happens in the mid-luteal phase in every cycle. This is the implantation window, 5-9 days after the ovulation. Again, we have some cells like natural killer cells, dendritic cells that invade over there, and we have some B lymphocytes and CD8 cells that escape endometrium. All this research is based actually mainly on a French immunologist who is called Lede, who has done a very big study regarding the personalized approach between 2012-2018 in 1,703 infertile patients, and it is a randomized control study. So based on that, it's the IMAP test that we use very often when we have candidates like that, which is a biopsy that is taken after endometrial preparation at a specific timing of the cycle inside the endometrium, and actually calculate some things that we will talk in the next slides. We have other tests as well, Matrix Lab, which is very similar, Chicago tests, which are blood tests as well. In our practice, we believe that it is better to check inside the lining of the womb with a biopsy rather than in a blood. And we believe that this needs to be done after endometrial preparation, because hormones play a role in immunology as well, as we will see. Now, I will pass this slide because it has many medical information on it that it will get complicated. I will talk about what actually this test, IMAP test, and what we need to check inside the lining of the womb at the time of the implantation window. Which things are we checking about? First, CD56 uterine natural killer cells levels. Second, interleukin 15 and fibroblast growth factor and the ratio between them. Interleukin 18 and the tumor necrosis factor, factor like weak inducer of apoptosis. This is the full name. I will not confuse you more with that. And all these factors are actually involved in the differentiation of the secretory endometrium towards the receptive state. What does this mean? It means that an endometrium adapts itself so that it can receive the embryo. And these are the cytosins, these are the things that actually play a role. What is important is a balance between the Th1 to Th2, and also in order to calculate this balance, we check the interleukin 18. What is happening actually is that the interleukin 18 plays a role in actually helping with the arteries to receive the trophoblast. But when we have overexpression of the interleukin 18, then this can become deleterious to the embryo, and it can cause a local toxicity, and it can cause a turn towards Th1. So just to understand, Th1, it causes cytotoxicity, Th2, it causes more reception of the embryo. And the same thing more or less happens between the tumor necrosis factor inducer and its receptor. What does it mean, personalized approach, actually? It means that we have some categories when we take this test. When we prepare the lining of the woman, we take the test at the right timing, which is the implantation window. The results come back as a balanced immune activation, which is characterized by normal levels of the ratios that we talked before and normal CD56. We can have a low endometrial immune activation, which is characterized by low ratios and an abscess of the uterine natural killer recruitment, and we have an over suppression of all these things. What I'm trying to say is that many times we say, okay, most probably it is immunology, and we say, okay, give steroids or give intralipids, for example, or IVIG. It's not like that, because many times we might find out that the problem is the opposite. It is not over activity, it is low activity. And we can have some mixed profiles as well. So what we are doing when we find out all these things, what we are doing, we can personalize the treatment. For example, people ask endometrial scratching, is it good? I mean, initially we had very good reviews about endometrial scratching. Then the latest reviews say no. Endometrial scratching is important when we have specific reasons. So endometrial scratching is recommended only in case of low interleukin 15 ratio, and when we have mature uterine natural killer cells, not when we have overactivity. Because this local inflammation, when it is done in the luteal phase of the previous cycle, can trigger a cascade and can help balancing this ratio. Even estrogens. Many times in the endometrial preparation, we give low doses of estrogen, high doses of estrogen. Why are we doing that? The doses of estrogen in a natural cycle are specific. So when we increase the estrogens, this is clear that it can downregulate the interleukin 18 expression. So when we already have low interleukin 18 expression, we do not want to further decrease it. So we will prefer to go with lower dose of estrogen rather than high doses of estrogen. So all the things, even the doses of the estrogen and the progesterone, have a thinking behind it. Immunotherapy. When we are doing immunotherapy, we're doing that when we have overactivity of the immune system, because we know, for example, that steroids, which is the first line of immunotherapy, decrease the levels of Th1, decrease the natural killers toxicity, limit the consequences of the interleukin 15 overexpression, and modulate the Th1 to Th2 balance. So this is when we give the steroids. If we give the steroids to people that have low activity, we will further bring it down and we might cause problems rather than benefits. When we have resistant cases, we can use the heparin as well, the Clexane. Why? Because we know that these anti-clotting injections have an anti-complement effect, which can help actually with the immune system. So they have some immunosuppressive results as well, apart from the anticoagulant results. And then, I mean, second-line treatments, it's intralipids, it's placanil, it's hydroxychloroquine. We give them depending on the ratios, depending, all these have some specific levels that we evaluate and we judge what we need to do, and we get a personalized approach. Regarding IVIG, it's a very good medication, because I'm sure that people will ask me, but unfortunately in Greece it's very difficult to find it. It's very difficult to get permission to actually administer it, etc. So we do not use it. Again, as I was telling before, progesterone. The progesterone actually causes immunological activities as well. For example, it inhibits the natural killer cells activity and leads to a Th2 dominant cytosine production. When we have a local overactive activation, then the high levels of progesterone before the embryo transfer can affect that, can modulate it, and can cause immunosuppressive results as well. So even the dose that we give of progesterones can play a role in the results. Many people ask me, okay, I want to have Ovitrel, beta HCG injections because a friend of mine had and she got pregnant. Okay, yes, it's a nice medication, but we need to know when to give it. When do we give it? We give it when we don't have mature uterine natural killer cells. When we have done the test and we have found out that actually we have immaturity of uterine natural killer cells. And in cases like that, we also advise, sexual intercourse after the embryo transfer. If we have overactivity of the immune system, we don't advise that because it can make things worse. You see all these things, and I'm trying to explain them just with simple as much as possible because it's a difficult topic, words, to understand that we need to know why we are doing everything. Lifestyle modifications, diet, exercise, body-mind techniques. We collaborate with Dusa in our clinic regarding this. All these things can help reducing the stress because the stress as well can change the immunology of the endometrium. Now, let's talk very briefly about the HLA-KIR genotyping. We do these tests in Greece. We do them when we have, of course, recurrent implantation failures or recurrent miscarriages. What is this? The natural killer cells recognize the embryo through the KIR receptors, which actually attach to the HLA-C embryo. Sometimes, because this is very complex, I will not go through all of it, but there are many different combinations of the HLA-C, C1, C2, and the KIR receptors that are many different variations. We have noticed that when we have specific combinations of HLA-C, for example, HLA-C2, and KIR receptors like KIR-AA, these can cause miscarriages. And when we find out that we have these issues, the problem is what we are doing. Well, actually, to be honest, the only thing that we can do is to advise to have one single embryo transfer and not two embryos. And sometimes, yes, some immunomodulatory treatment can help, especially here the GCSF, the Neupogen. Endometriosis. Endometriosis, many different theories about what is causing endometriosis. One of the theories has to do with immunology as well. We know, for example, we have macrophages, lymphocytes, natural killer cells in the peritoneum. And we know that many times this thing is also affecting the endometrium. And we have many times deranged immunological activity in women that have endometriosis. So when we have a patient with endometriosis that has recurrent implantation failures and recurrent miscarriages, we have a lower threshold about checking about immunology. Endometriosis is also associated with a chronic infection many times. So, when we find out that we have a specific issue, antibiotic treatments or immunosuppressive treatments can help as well in the implantation. Last slide. The implantation window mechanisms are not completely clear. We have many local factors that affect. The balance is very, very important. Each person, and this is the most important of all, has its own immunological profile, and this immunological profile can change. It can change even in 6 months. The immunology in the blood does not always correspond to the local immunology in the endometrium, and that's why we prefer to check it inside the endometrium. The hormones play a role, and they can affect progesterone, estrogen, they can affect the immunology. And because of all this, the personalized approach is very important. Do not go blindly on treatments, especially in cases of recurrent implantation failures. Find out first what is the issue. And of course, in all these cases, it is very important to first know that we have a healthy embryo. Because if we put embryos inside and we deal with immunology without really knowing that this embryo is chromosomically normal by PGTA, if it fails, we will not know the reason.
Brilliant as always. Thank you so much for walking us through all aspects of immunotherapy. It's not an easy one, as we mentioned before. So now will be time for your questions. So everyone, if you have any questions, you know what to do. There are some questions ready. We have about 5 minutes for the questions, so don't hesitate, okay? And let me just go for the first question that we've got. And I will show it to you as it is quite a longer question. Just give me a second. For some reason I cannot display it. I just need a minute. Something happened here. Okay, now it's working. I want to know what you think of checking my immunology status, immunophenotyping, and the determination of the tolerance potential by measuring the regulatory T cells. My fertility clinic doesn't believe in this approach, so I would need to do it on my own. I'm 42, 6 IVF transfer so far with blastocysts A and B quality, frozen eggs from age 37, as well as fresh ones this summer. AMH 1.9, AFC 10. No implantation so far. Everything else looks good. No sign why it should not implant. Anything you can advise?
Yeah. Listen, because you started doing your IVFs from the age of 37, to be honest, when you have 6 transfers and it is not working, yes, to check about other things and to check about immunology as well, it's something that it could be important. But if you haven't PGT-ed the embryos and you are right now 42 years old, the first thing before spending money and time in all these tests, before you do all that, is to do a PGT-A, is to get a chromosome analysis of the embryos and find out if the embryo is chromosomically normal or not. Because if you don't know that, even if it is good quality, when you transfer it back, you will not know what were the chromosomes inside.
I have added PGT-A, not allowed in Germany. Yeah.
It's allowed in other countries. It's important, okay? And when you are 42, the benefits, outweigh the risks a lot. And when you have a history of recurrent implantation failures like that, it's the most important thing. When you know that you have a healthy embryo, especially if it is just one embryo, this is a very precious embryo. And then, yes, you need to check about other things as well. Hysteroscopy, immunology, chronic infection, not only immunology, other things as well. But yes.
All right, Verena, I hope that helped. But of course, someone is typing possibly. If you have any follow-ups, you just know what to do. We will go back and there's a thank you from Verena. Thank you so much indeed. Let's move on to another question here. How long do the results take from the EMAP test? Can you do an embryo transfer in the next cycle?
Well, usually with IMAP test, you start preparing the lining of the womb with the same way that you would prepare the lining of the womb at the time of the embryo transfer. So you take estrogen, then progesterone, you don't take anything else, and you take the biopsy at the time that you would do an embryo transfer. The results come back in about 10, 15 working days, and you do get the results. And then we can go through the results and we can create a personalized approach to you. And we follow this approach at the time of the embryo transfer. That can happen with the next cycle, yes.
Okay, I hope that was clear for you. Thank you so much. And let's have a look. Next question. I have NK cells high in blood test, but which test can I do to see if it is high in uterus? I only had natural pregnancies, but then spontaneous abortion after 3 IVF, no pregnancy.
Okay, I don't know what test you have done in the blood. As I said many times, when you have done this test in a random phase of the cycle, without hormonal treatments, the natural killer cells in the uterine is not always the same like the natural killer cells in the blood. We prefer the test in the uterus. We do a test which is called IMAP of IGLS. There are other tests as well, like Matrix Lab, and this is the one that we are doing.
Mm-hmm. If there's anything else you wish to add, again, you know what to do, okay? if something is not enough for you or clear. So let me just go to the next question. More questions are coming in, so bear with me. I need to display this one. So why do some patients with high NK cells or N activity who are under immune treatment, steroids, aspirin, and clexane, still end up having further miscarriages?
Well, there are many factors of why someone will have a miscarriage. First of all, it's not only immunology that is causing miscarriages. Second, as I explained before, what test exactly have you done to find out about your immunology problems, and what protocol are you following because of that? Is it a personalized approach? Is it just taking steroids because in the blood you have raised natural killer cells? Might not be exactly the perfect way of dealing with it. But by any means, even if you are taking all the medication, and even if you do have oversuppression overactivity inside the uterus, there are other things that cause a miscarriage. For example, the chromosomes of the embryo, chronic infections, sperm DNA fragmentation that goes inside the embryo and causes chromosomal problems in the embryo. Scar tissue, diaphragms, septums, which are identified by hysteroscopy, fibroids. There are many things that can cause a miscarriage. And the most often ones is actually the chromosomes. It's actually the embryo itself.
Okay, brilliant. Thank you once again. I will now go to Verena's question, okay? The previous patient. So she has a few questions here. So should I also check the immunology of my uterus? Because you mentioned earlier that it should not be done in the blood. I took antibiotics prior to my last IVF for 14 days, doxycycline. Does this only help with potential silent inflammation or also has an effect of the immunology of the uterus?
Well, again, regarding the antibiotics, if someone has a history of recurrent miscarriages and recurrent implantation failure, we prefer to do a hysteroscopy and identify elements of chronic infection. The cultures that we do to the vagina do not always correspond in what is happening inside the lining of the womb. We take PCR samples of inside the lining of the womb regarding chronic infection, and when we do have a reason, we give antibiotics, triple scheme of antibiotics or something else. And many times it is combined with probiotics as well. To cover about doxycycline without really having checked before, it's relevant because if you don't know if you have, for example, ureaplasma, mycoplasma, chlamydia, or anything like that, it's better to prevent, to spread an infection and cover with doxycycline. But when we have a patient with recurrent implantation failures, it is better to know what we have inside the lining of the womb, what infection we have, and then give the relevant antibiotics. Now, regarding the first question, yes, we are big fans of checking inside the uterus and not only in the blood, but not to everybody. I need to say that in people that do have unexplained failures, do have recurrent implantation failures, do have recurrent miscarriages.
All right, brilliant. Again, thank you. And all right, thank you from our patient here as well. And Nicole has another question. I've had 7 failures with steroid usage, normal NK cells, beautiful endometrium, started at 48-year-old with donor eggs on my 3rd clinic and suggested to take, not sure, I'm afraid here.
Most
and
probably
I am candidate for this. Interlipids, okay.
It's again, what I was saying before. I don't know where you've checked about the natural killer cells, most probably in the blood, but your natural killer cells are normal. So why to take intralipid? Intralipid actually is used to reduce the overactivity of the immune system. If the immune system is working properly and you have done the tests, why intralipid to be the benefit. I don't know the case. I don't know what you have done. Might be, but again, our approach is to do things knowing why we are doing them.
Good. All right. Thank you. Let me show you the next question. A few more details from Lena. So I'm 35, also had 6 failed embryo transfers, A-B quality without genetic testing, 4 negatives, 1 missed abortion before 6th week, 1 empty gestation sac. I have endometriosis stage 3, not that much lesions in abdomen, but endometrioma 5 centimeters, light diffuse adenomyosis of posterior uterine wall. I have very low IgG of unknown cause. Last transfer with IgG infusion covered by insurance in my country, but transfer ended with empty. Sorry, not sure again. What do you recommend?
Empty gestational sac. Okay, I have endometriosis stage 3. Okay, it's a very complicated case. Listen, after 6 failed embryo transfers with good quality embryos, I would again do PGPA. The first thing is to know that you have an embryo that is chromosomically normal, because with a stage 3 endometriosis, unfortunately, this affects the ovarian reserve. It affects the quality of the eggs as well sometimes, and many times we do not have chromosomically normal embryo. So the issue might be just the embryo. So the first thing that I would do after all these failed transfers is to know that I have a chromosomically normal embryo first. And then I would go and break it down to all the things that can cause the miscarriages. Thrombophilia checking, of course, to see if you need declotting injections and aspirin and things like that. Test about immunology to create for you a personalized approach if needed. Checking your progesterone levels because of your endometriosis before the embryo transfer. Many times we have a progesterone resistance in severe endometriosis patients. All these things, breaking it out, and then transfer after we have a personalized protocol for you.
Okay, let's move on to the next question. Lots of them are here today. So next one is, what are your thoughts on the treatment with combination of hydroxychloroquine, prednisolone and aspirin and eclexane for a patient with elevated NK cells levels and activity? Do steroids and aspirin actually reduce the level of elevated NK cells and activity?
Yes, I mean, all these medication help in that. Of course, it depends on the levels. So initially we start with steroids. Sometimes we need additional treatments like Placanil, like hydroxychloroquine. Aspirin does not actually affect the immunology that much. It plays a role with the blood flow mainly. Clexane can also help with, apart from the coagulation, with the immunology as well. All these are medications that when you have increased activity of natural killer cells, when you have Th1 balance predominant, they can help with reducing the immunology activity of the endometrium. So yes, they are medications that we use them. Usually we use them in more, the combination of all this in more resistant cases.
Okay, thank you. I will go now to the follow-up. If I were to have only one intralipid infusion before the embryo transfer, would that make any difference in my NK levels and activity? Also take prednisolone, all the things you see right here.
Listen, usually the combination of all these things, we don't, I mean, at least in our practice, we don't use all of them. We have first-line treatments, second-line treatments. If you take hydroxychloroquine, which is the Placanil, it's a very potent medication, and it's a very good medication for really increased activity of natural killer cells. We don't combine it. We usually use either one or the other. But of course, you follow the advice of your doctor as well, because every clinic might have different protocols.
Right. Thank you. Talia has another question. So what other tests do you recommend, and how many biopsies can you safely do in one go?
Sorry, can you?
Sure. Here it is.
What do you mean biopsies in one go? About what? Tests about what?
I believe so, but
I mean, the immunology testing is usually we use the IMAP testing. I mean, at the same time, during the time of the hysteroscopy or during the time of an outpatient procedure, we can take biopsies for the endometrial flora as well. If we have a predominant lactobacilli or not, we can take about chronic infection. We used to take about implantation window as well, but the latest studies regarding implantation window are in favor of not doing it anymore, even though in our practice, when we cannot find anything else, we did have some cases with, success with the implantation window displacement as well, and we are using it. Yeah. So
okay.
there are.
There's one more question. Can you do these tests, so IMAP, without traveling to Greece?
You can do them in your country, possibly, if you find them. I don't know. You need to find a unit that will be collaborating with that.
Right. Okay. And Natalia actually has a follow-up to clarify how many samples can be collected in one procedure so that the endometrium isn't affected.
You can do that with EpiPel. You can do it at the time of the hysteroscopy by taking biopsies, small biopsies with scissors. So it's not a problem. We don't have issues. We usually many times take all three of the tests together, and it doesn't affect the endometrium. Instead of scraping the lining of the womb massively, I mean, what you can do is with scissors, you take the biopsies inside, and you don't affect anything.
Okay, crystal clear. More questions are coming up, and so let me just go back to the previous ones. Sorry. I have adenomyosis diffuse. I don't have bleeding, but I have inflammation. How can we stop? How can I stop that?
What sort of inflammation? Well, about adenomyosis, you cannot, it's something which sometimes it is associated with endometriosis, sometimes it is not. Adenomyosis is a very difficult task that you cannot do many things. Usually when we have adenomyosis in a woman that has still its cycles and has its hormones, so she's not in menopause, we prefer to down-regulate before the embryo transfer so that we can make things a bit better. The inflammation, I mean, I don't know what sort of inflammation. How did you find out about this inflammation? Is it a specific inflammation? I mean, usually you need to take antibiotics about inflammations inside the lining of the womb.
All right. Okay. Thank you. Let me just go to our next question. Once again, I just need a minute. Yep. Are all three tests important to do? Saline sonogram, HSG, laparoscopy?
Well, it depends on why you are doing them. If you have suspicions that there is a polyp, a saline test might tell you if you have a polyp, but then it cannot treat at the same time. So the most accurate thing that you can do is just put a camera inside, because at the same time you can treat as well if there is a polyp, and you can also see the lining of the woman. You can get information that you might not be able to find out in HSG or ultrasound scans, for example, signs of a chronic infection or a small degree of scar tissue. Now, regarding checking the tubes with HSG, if we have suspicion of hydrosalpinx, if we need to check about the tubes, okay, we do the HSG as well. But usually with IVF, if we do not suspect hydrosalpinx, we don't need to check about the tubes. We are not interested on if the tubes are blocked or not, as far as they don't have fluid inside.
Okay, there's actually more information from the same patient, from Hannah. Okay, so I have an MRI to rule out any uterus issues in February. Must I repeat the test? I have had one implantation failure, one failed pregnancy. And what test would you recommend to repeat if I have only elevated TPO, thyroid, and taking medications for that?
Okay, who is this patient?
From the previous, actually, the previous Hannah, she asked about, let me just go back. Yeah, she asked about the test, like silent sonogram, HCG.
Yeah, laparoscopy, sorry, laparoscopy was the question, and I was talking about hysteroscopy before. Laparoscopy, you know, you don't actually use it. I mean, laparoscopy is important about endometriosis, but if there is a mild degree of endometriosis, when you do laparoscopy and you treat the laparoscopy, you increase the chances of spontaneous conception. But if you don't have severe endometriosis inside your ovaries, which will be obvious in your MRI and your ultrasound and things like that, to do a laparoscopy before the IVF, it wouldn't really contribute in anything. You can just downregulate your ovaries if you know that you have endometriosis in order to do an embryo transfer. Now, MRI, it's good that you have done it. It can show if you have any spots of endometriosis. It can show about fibroids and things like that. I mean, AMH, hormone tests, sperm analysis, check very nicely about the sperm as well. All these are tests that you need to do. And the next step is to start stimulating your ovaries, create some good embryos. And then, given of your history, I don't say that it is 100% important to check about immunology as well. I mean, you don't drop into the category of recurrent implantation failures or recurrent miscarriages from your history.
All right, thank you so much. There are more questions coming up, about 13 minutes to go, so let's have a look, okay? Kate would like to ask you, is it possible to have immune issues after a previous successful pregnancy? I have had 4 failed embryo transfers with genetically normal embryos, so wondering if immunology now may be an issue.
Yes, it is possible. We have seen it many times. We have many times, primary cases and cases that we have a previous normal pregnancy, and then we do have miscarriages in the next pregnancy. So yes, I would check about immunology. First of all, immunology is associated with many autoimmune conditions, and you could have an autoimmune condition as well that you didn't have before.
Okay. Thank you. Short question here. Is this drug effective? Are you familiar with it? Not sure. So
Let me.
Sure.
Most probably, I'm missing something here. Wait.
Let's have a look.
Yes. Okay. I very recently read some studies behind it. Can you find that? Because we were thinking about, when we had a first contact with the guys that have created this medication, it was still on a research trial, so we couldn't really use it. I don't know if something has changed. I mean, I've read some research behind it. It's interesting the way it works. I don't have experience. I had a contact with them regarding the specific medication because, the name came and I needed to Google it as well. I mean, I cannot really tell you because I don't have any experience myself with the use of it.
Makes sense, of course. Thanks a lot. All right. Again, few details here, and let me just display it again. 41, I have had 2 failed embryo transfers. Unfortunately, I cannot afford to try IVF again because it would have to be with donor X. I have hypothyroidism, KIR AA with C1, both me and my husband, polyfibromatous uterus, antiphospholipid syndrome, thrombophilia factor 5 laden, heterozygote, and is there any chance of getting pregnant naturally?
Wow, that's a history, medical history, very complicated. But things are very difficult. I don't know about your FSH. I don't know about your AMH. In 41, the chances of getting pregnant by yourself are very low. And also, even if you get pregnant, of course, you will need to take under control the thyroid problems. Might need some immunology treatments as well regarding the HLA-KIR issues. To be honest with you, the chances are extremely low, and egg donation would be the best option for you right now.
Okay, thank you. Thank you for answering this question. Let me just show you next one. If adhesions are found during hysteroscopy and they are removed, how long for them to come back if they do?
It depends on how much of adhesions, to be honest with you. When we have a lot of scar tissue inside, usually we put an IUD as well that keeps the walls of the uterus, dilated so that the adhesions will not come back. Sometimes we give some estrogen treatment as well to help proliferating the endometrium so that they don't come back. But many times they do come back. Now, how long? Usually not imminently. But it depends on the degree of adhesions, and it depends on if it was a septum actually or adhesions, because I think I know Maria. Yes, depends on its case. It's not for guaranteed. When you do have scar tissue inside, many times the scar tissue comes back again.
Okay. Thank you. There are three kind of questions with some information. Let's have a look. I have adenomyosis with endometriosis in bowel and ovary affect the implantation and pregnancies. The same patient, KIR, AB, C1, C1 both affect uterus and implantation. I have my MH 0.5, FSH 11, age 43. Anything you can advise here?
Well, if you are interested about IVF with own eggs in the age of 43, the first, and with that low AMH and borderline FSH, the first thing is to create some embryos and to biopsy the embryos to see if you will manage to create a chromosomically normal embryo. The chances are low. If you don't manage to create a chromosomically normal embryo, then we are talking about egg donation. Now, regarding all the other things, given of your HLA-KIR situation, you will go most probably with one embryo transfer. There are some theories behind giving you GCSF as well treatments. And regarding adenomyosis and endometriosis, if you do have a regular cycle, after we have created the embryos, I would down-regulate before we transfer the embryo back. But the first thing is to manage to create a chromosomically normal embryo, which is difficult.
Thank you. If you have anything else you wish to add, there will be final call for your questions. Someone is typing, so let's give it a minute. I do believe that we answered all of those so far. If not, if I missed anything, please just paste this once again, okay? I hope not, but not. There are many questions today. Okay, can garlic ginger drink have effect on IVF medication?
I'm not familiar with something like that. I don't think so.
All right, the crystal clear. And we did receive another question. Let me just display again quite a few details. I don't have a thyroid anymore, taking L-thyroxine 125 pills. My TSH level is at 0.8 normally, but when measuring the level while doing simulation, my TSH level increased to 3.8. Should I maybe increase the L-thyroxine pills prior to stimulation?
Listen, you need an endocrinological input. Maybe you will need to increase a bit. The ideal levels of TSH before embryo transfer are less than 2.5. We generally try to balance it so that it is on these levels. Of course, it depends on your anti-TPO antibodies as well. If it is a matter of thyroiditis, or I mean, I think you say that you don't have a thyroid, so it's a replacement treatment. Talk with your endocrinologist. Maybe you will need to increase a bit the dose, or measure it at the time of before the IVF. Before the stimulation, and if it is higher, you increase the levels to drop it below 2.5.
Okay, brilliant. Thank you once again. One more question. For someone with immune and clotting issues, how many euploids do you recommend for one child to get one child, I guess?
Well, the more the better, but because you never know if it will work. But even if you have one, it's a very precious embryo. It gives you very good chances. I mean, thrombophilias are dealt with nowadays with anti-clotting injections and aspirin and things like that, so it shouldn't be a problem. So, of course, the more you have, the more you have chances, if the first one fails, to have a backup, of course. But even one is an important embryo. Make sure that you will put it under the best circumstances.
Okay, excellent. Thank you so much. We will be slowly finishing. I think that there's a final question from Lena. So thanks a lot, Dr. Harry. You can see that there are plenty of thank yous coming up your way for answering. So thanks a lot for that. And let me just go to this question from Lena right now. Sorry, just again a second. Here it is. With endometriosis and adenomyosis, how exactly your personal downregulation protocol looks like before embryo transfer, for example, starting 1 BC, or mid-luteal 2-3 months, waiting for period, or starting estrogen, progesterone preparation, for example, 7-10 days after last shot. Anything else?
Well, depending on how big is the endometriosis, what stage of endometriosis, etc. Usually, we give one-off downreg injection in the luteal phase of the previous cycle. Sometimes we do a double one, so 1 month, second month, and then we start the preparation. So we are waiting for a period, and we start the preparation. That's usually what we are doing. But of course, every clinic might have a different approach.
Of course. Okay. Thank you so much once again. And I think I missed before a question from Nicole, and I will show it now. Estrogen and progesterone regimens before transfer cause me excess fluid up to extra 15 within 2 weeks. Would this excess fluid cause inflammation of the uterus?
I don't think it is really associated. You might have a bit of fluid retention with all this medication. I mean, regarding inflammation, I wouldn't say that it really would cause an inflammation of the uterus.
All right. Again, hope that helped. I do believe so. As I mentioned, plenty of thank yous you're coming up your way, Dr. Harry. We will be finishing for today. Natalia, short one, I think we can still answer. Natural medicated cycles for transfer and why?
Listen, if we are talking about medical tourism and people coming from abroad, to be honest with you, the medicated cycles are very much easier to coordinate them. In a natural cycle, you take a risk of having ovulation, you have a risk of measuring the blood tests, etc. So we usually prefer to go with medicated cycles. But a natural cycle as well, especially in women that have completely regular periods, because when you don't have regular periods, it's not easy to control it, should be okay. So if we find a way of doing it and understanding the risks of missing an ovulation, traveling to Greece, and not being able to do an embryo transfer and things like that, it's one of the things that we really like. And sometimes when we have failed embryo transfers, or biochemical pregnancies with medicated cycles, we have seen sometimes that a natural cycle might increase the possibilities of a normal pregnancy. But everything needs to balance towards advantages and disadvantages.
Brilliant. And with that, I believe we will be finishing for today. But of course, you'll see lots of questions we had, and there are plenty of thank yous coming up your way. If someone would like to have a consultation, someone asked for it actually, you can definitely email me or Dr. Harry directly, and I'm sure he'll be happy to simply do that. And just to confirm, Dr. Harry Karpouzis was our special guest today. Thank you so much, Dr. Harry. And just to remind everyone, Dr. Harry is the scientific and the director of Pelargos IVF, which is located in Athens, Greece. So that was a very interesting session, plenty of questions. So thanks a lot, everyone, for your time. And Dr. Harry, as always, thank you for your time. Any final words before we finish for today?
Nothing. It was nice to see you again and see everybody. I hope I've helped. And I wish Merry Christmas to everybody.
Definitely. Thank you so much, everyone. I just want to say that we will be back on Thursday, and on Thursday there will be our last event this year. Don't worry, we will be back with more events next year, and I'm sure Dr. Harry will join us on more than one occasion. So stay tuned. Thank you so much, everyone. And right now you will be redirected to our survey, so I can only encourage you to take part in it. 2 minutes, and let us know what you think about this webinar, all of our webinars, but also share anything that you would like to perhaps for us to discuss, because there is a question about the topics you are interested in as well. So don't hesitate. Thank you so much, everyone. Have a lovely evening, and of course, I hope to see you back here on Thursday as well, Dr. Harry.
Thank
Speak
you.
soon.
Bye-bye.
Merry Christmas. Take care. Bye.
Bye.